Jahangir could start.
Okay, good afternoon. All right. Good afternoon and good evening to everyone who have joined so far. I think few of our panelists still on the process of joining, but we will start our case presentation at the moment. Thank you very much, everybody. I know their busy schedule coming for this webinar and enriching us with their experience and with an interesting talk we have got today. Uh, so I'm Saeed Sadiq. I'm working as a consultant cardiac surgeon in Sheffield Hospital, as well as I'm actually the faculty lead of this Planetary Health Academia. And me and Shakil Bhai were organizing these teachings routinely for our, especially for our trainees all over the countries, including UK, Bangladesh, and everywhere else. So we have got an excellent speaker today and a huge group of learned panelists. I think the talk will be very excellent today. I mean, Mr. Livesey, it doesn't need any introduction, but those who doesn't know Mr. Livesey, just to say that I actually had the opportunity to work with him. Mr. Livesey has recently retired, just a week, 2 weeks ago, isn't it, Mr. Livesey?
End of March. End of March.
Yeah, yeah. So Mr. Livesey is as a consultant cardiac surgeon working NHS UK for years and years. His last post was the associate medical director and the clinical lead in St. George's Hospital. He was the clinical lead in Southampton Hospital before that, and I had the opportunity to work and get trained by Mr. Livesey. He has trained so many of cardiac surgeons in this country who are working as a consultant surgeons in different places in UK and also outside UK. And we have got one of our panelists, Professor Hunaid Vora, who was a direct trainee of Mr. Steve Livesey and himself is doing really well. Mr. Livesey, thank you very much for joining this talk, and I would really appreciate you have given your time for us today. I will quickly go through our panelists. So we have got Professor Hunaid Vora, who's working as a consultant cardiac surgeon in Bristol Heart Institute. Hunaid and I had the opportunity to work as a registrar and learned a lot from Hunaid as well. Professor Hunaid Vora his main expertise in minimal invasive surgeries. He is not only a trainer, but also in help in developing minimal invasive practice in different centers. Thank you, Professor Vora, for joining today's session. We have got Dr. Neil Cartwright. I'm not sure whether Neil has joined yet or not, but I just had a chat with him. Oh, yeah, thanks for, yeah. Yeah, Neil, do you want to turn your video on for us to see your face?
Oh, yeah, sorry, yeah.
Yeah.
I can't see. I'm used to Teams, so yes.
Yeah, no, that's all right. Yeah. So Neil is a consultant colleague of mine, and his main specialty is mitral valve repair and mitral surgeries and AF ablation. He is also the local training program director for training of the Sheffield Teaching Hospital. We have got Professor Jahangir Kobisa. Jahangir Kobisa has been kindly joining with our sessions for a long time. He's the chief cardiac surgeon and the director of the Cardiac Center United Hospital. And I have to say, I had the opportunity and was lucky enough to get trained by Jahangir Kobisa when I was in my early years of cardiac surgery back in Bangladesh. Jahangir Kobisa has got a huge experience in all aspects of cardiac surgery, both congenital and adult. And hopefully we will learn a lot from him today through this talk. We have got Professor Farooq Ahmed Sir, who is the Chief Cardiac Surgeon of National Heart Foundation Hospital and Research Institute, and also current President of the Cardiac Surgery Society of Bangladesh. Farooq Ahmed Sir, I also had the opportunity to work with him. He has huge experience in all aspects of cardiac surgery, especially in mitral valve repair, and hopefully we will learn a lot from today from you, sir. We've got Dr. Shakil Farid, consultant cardiac and aortic surgeon in Royal Papworth Hospital, also the trustee of Planetary Health Academia, who has started this venture to go help with the learning process from our country and also to with the Bangladesh. And now it has actually has gone so many umbrella. We have branches now, and it is progressing very well. Shakil Bhai, thank you very much for joining. And as usual, he helped us organizing this talk. I've got Dr. Prashanta Kumar Chanda, Associate Professor and Senior Consultant in Cardiac Surgeon in Square Hospital. Dr. Chanda has always usually comes and joins as the panelist and has got huge experience in all aspects of cardiac surgery. We have got Dr. Ashraful Haq Siam. He's an Associate Professor in Cardiac Surgery in NICVD Hospital. Is the National Institute of Cardiovascular Disease Hospital in Bangladesh. He's also working really hard and have already established an excellent minimally invasive practice in the first time in a government sector hospital in Bangladesh. I'm really proud because he's actually my batchmate. I'm really proud of what he has achieved so far. We've got Professor Shumon Nazmul Hussain. He's professor and head of the cardiac surgery department in Chittagong Medical College Hospital. Thank you very much, Shumon Bhai, for joining today. We have Dr. Harun Roshi. I had the opportunity to meet him very briefly in 2006 when I was in National Heart Foundation Hospital. Dr. Harun Roshi is an associate professor and senior consultant in cardiac surgery in Heart Foundation Hospital, and also specialize in mitral valve repair and mitral surgery. And last not the least, we have got Dr. Arman Wadud, associate professor and consultant cardiac surgeon in Ibrahim Cardiac Hospital and Research Institute, and also another minimal invasive surgeons. And I'm really proud what he has doing so far in his practice. So without any further ado, I'll kindly ask Mr. Livesey to start his talk. Just for our audience, if you have any questions, please feel free to put it on the chat, or at the end, if you want to speak about that, just raise your hand. We'll give you the time and opportunity. And hopefully we all will enjoy Mr. Livesey's talk. Thank you very much.
Okay, thank you. Okay, thank you. So it's important in any branch of surgery to have a full understanding of the anatomy. So I always start these talks with a brief run through of the very basics. And as you can see from this diagram from Carpentier's excellent book on reconstructive mitral valve surgery, the mitral and tricuspid valves lie essentially in the middle of the heart and are really quite complex valves, whereas the pulmonary valve and the aortic valves are simple semilunar valves which lie just in vessels themselves and are much simpler structures. It's important to understand what happens to the mitral valve in the two phases of the cardiac cycle, in diastole and systole. In diastole, the valve is wide open. And that's why, particularly the posterior leaflet has these clefts, which we will talk about later, but it demarcates the three segments of the posterior leaflet. If we didn't have these clefts, then the valve couldn't open fully. In systole, the valve shape changes and the valve becomes smaller. Now, systole is the shape that we fix the valve in when we do a mitral valve repair, when we use a complete ring. So you can see we have changed both the shape and the size of the valve when we do a mitral valve repair. There's quite a marked difference in valve area between systole and diastole. The valve area goes down by just over a quarter during systole. And remember, that's the shape that we fix it in. Now, of course, in chronic mitral regurgitation, there is always annular dilatation. So we are, in fact, bringing the valve back down to a more normal size, a normal shape when we use an annuloplasty ring. Let's look at some of the anatomy. The circumflex coronary artery runs very close to the valve, and it's probably closest in this area here by the anterior commissure and comes down through this area here related to the P1 scallop of the valve. This is a CT scan where the other structures have been taken away and we're left with the circumflex coronary artery running very close here to the commissure and down through P1. And it's important that we bear that in mind whenever we put stitches in this area, lest this might happen. Here you can see the circumflex coronary artery stopping here just by the anterior commissure part of this mitral ring. So we should not place our stitches too deeply here, but rather a large horizontal stitch is probably better as we go down from the anterior commissure through to through P1. So we've talked about the circumflex coronary artery. The other structure that we can damage is the aortic leaflet. So when we're placing any stitches along the base of the anterior leaflet, particularly from about here round towards the anterior commissure, we need to be mindful that the aortic valve leaflets are right behind us. A couple of other important structures, the bundle of His. It's quite hard to hit the bundle of His in everything except a congenital surgery, really. So we tend not to worry about that too much. And the coronary sinus, whether or not our stitches penetrate that, I've never been aware of anybody having an issue with damaging the coronary sinus. I think if a stitch goes near there, it doesn't really cause any problem. Okay, let's look at the chords. There are three. Could somebody turn their microphone off? It's so there are three basic types of chords: the marginal or primary chords, intermediate or secondary chords, and the basal chords. And these chords have quite different functions. The marginal chords are the chords that cause coaptation, which leads to the competent valve. The secondary chords are thicker and they attach to the mid part of the mitral valve leaflets, and they're there to help restrain the leaflet against systolic blood pressure. Excuse me. The basal chords are attached at the base of the leaflet, almost onto the annulus, and are important for maintaining the ellipsoidal shape of the ventricle. And we should avoid cutting those. So here we see the fairly thick secondary chords and the very thin primary chords here. This study was done putting pressure transducers on the chords and looking what happened throughout the cardiac cycle. And you can see the primary chords face very little pressure during the cardiac cycle, whereas the secondary chords really experience systolic pressure during systole. So this is important in mitral valve repair because the primary chords cannot restrain systolic pressure for very long if we don't have leaflet coaptation to maintain closure. If we just relied on the primary chords, the repair would not last very long at all. Just to look at the nomenclature, it's important that we all use terms that we understand so we can communicate with each other, with our echocardiographers, with our cardiologists, with our anaesthetists, etc. So there are 6 named parts of the mitral valve: the anterior commissure and the posterior commissure. This is the surgeon's view. And the 3 scallops of the posterior leaflet, P1, P2, P3, separated by these clefts. The anterior leaflet does not have clefts, but it's named for the parts of the posterior leaflet which it lies against. So A1, A2, and A3. Few more terms. So coaptation, normal coaptation occurs and the leaflets meet at the annular plane. They do not go beyond the annular plane. Prolapse is where the tip of the leaflet moves beyond the annular plane into the atrium. Billowing is not prolapse. Here, the leaflets are billowing into the left atrium, but the tips are below the annular plane. So this is not prolapse. This is billowing, though of course this may eventually result in prolapse with billowing and prolapse, but here the tip now goes beyond the annular plane. And finally, a look at the functional classification introduced by Carpentier. This is dysfunction according to leaflet motion. Type 1 dysfunction is normal leaflet motion, but the leaflets either don't coapt, as in angular dilatation, for example, secondary to atrial fibrillation, or there's a hole in the leaflet in endocarditis. Type 2, this is where we have leaflet prolapse, where we have excess motion of the leaflet moving beyond the angular plane, and it is certainly in the West by far and away the commonest lesion we see in the mitral valve. Type 3B is restricted leaflet motion. Type 3A is only really seen in rheumatic mitral stenosis, where there's a restriction in diastole. Type 3B is commonly seen in ischemic mitral valve disease, where the leaflets are restricted by the dilated ventricle and don't get to reach the annular plane. So there's regurgitation because of that. So Alain Carpentier had three principles of mitral valve repair, which we should try and adhere to when we're doing mitral valve surgery. That's to preserve or restore normal or full leaflet motion, to create a large surface of coaptation, because it's the surface of coaptation that maintains the longevity of the repair, and to remodel and to stabilize the entire annulus with a ring. So this is a case of mine of a posterior leaflet repair. Here we have a posterior leaflet prolapse. This looks to me like fibroblastic deficiency, where there's not much excess tissue in the posterior leaflet, but here you can see there's a ruptured cord with a flail and a posteriorly directed jet of mitral regurgitation. So we'll look at some of the techniques that are available. Quadrangular resection was for years the mainstay of mitral valve repair. Carpentier popularized this, and I certainly used it for my first 5 years doing mitral valve surgery. And I don't remember any patients coming back with mitral regurgitation with this technique. Triangular section we'll talk about a little bit. Sliding plastic chordal transfer and artificial cords, I'll just mention. So quadrangular resection, it is what it says. The prolapse here of P2 is resected vertically down to the annulus and divided through there. These are about the maximum dimensions that you can successfully do a quadrangular resection. Any wider resection than that, and SAM may well result. As you can see, it's a very simple technique to do. Some stitches through the annulus now there and there to close the annular defect, and then suture the leaflets together. It's pretty straightforward. So its main advantage is its simplicity and its reproducibility and its teachability. But the disadvantages are that only a limited resection is possible. It really does only work well in P2. It removes good tissue, thus reducing the amount of tissue that's available for coaptation, and the annuloplasty is performed in one area only. I think there's also a theoretical risk of kinking the circumflex coronary artery in this technique. So this led to the triangular resection, which in many ways is similar in that the only part of the leaflet that's resected is the prolapsing part of the posterior leaflet, but this does not go right down to the annulus, and there's no resection at the annulus. It's fairly simple to close. Now, this relies on the annuloplasty, an annuloplasty ring, to reduce the size of the annulus, whereas the quadrangular resection, you're reducing the size of the annulus itself by your annuloplasty sutures. This again is very simple. It's very reproducible. It's good that it preserves tissue, so there's more tissue to coapt. And using an annuloplasty ring, the annuloplasty is performed over the whole annulus rather than just in one small area that it is with a quadrangular resection. The disadvantages are that only a limited resection is possible, and I felt it often needed supplementation with artificial cords. In fact, I always supplement it with artificial cords. Putting the sliding plastic, just to mention it, this technique is used in two situations. Firstly, where you have to resect more than the 2 centimeters that were suggested for a pure quadrangular resection. It's also particularly helpful if you need to reduce the height of the posterior leaflet, but also for getting at the annulus where you need to resect calcium. The technique is relatively straightforward. The resection of the prolapse is done, then the posterior leaflet is dissected, away from the annulus for quite some distance. These sutures that Carpentier called compression sutures are placed, which when they're tied brings the annulus back down together. The leaflet is then sewn together, then sewn back down to the annulus, and a ring's placed. I used to do it a lot. Now I only ever do this if occasionally in a Barlow valve, but mainly when I need to resect annular calcium. And finally, coming on to artificial cords, this for me became the mainstay of mitral valve surgery. The only material that works for artificial cords is EPTFE, for which the commonest is Gore-Tex, and I used Gore-Tex that had little pledgets, and you place them, which I will show in videos, if you can, through the fibrous cap of the papillary muscles. So let's look at a case. Posterior leaflet prolapse, bit of excess tissue here. Looking at in the bicommissural view, you can see the posterior leaflet here popping up above A2. So this is a video of a posterior leaflet repair, placing some traction sutures through the annulus to improve the view, and these will also later be used for placing through the annuloplasty ring. You can see P2 coming into view here, this large hood of excess tissue. Coming around to P3 here, placing another suture to deliver the valve. Here we have P2 with a ruptured cord. As you can see, lots of excess tissue. This must be 3 centimeters in height, probably. But using artificial cords as a technique means that you don't actually have to resect tissue, because you can pull the leaflet down into the ventricle, which gives the opportunity to have a really good coaptation distance. So now I'm just placing some Ethibond sutures around the good cords at either side of this prolapse. I'm going blunt end of the needle first, so I don't go through any tissue. I just use this to demonstrate and to show the leaflet and its for the full extent, so I can mobilize and get the stitches. And here we have the first set of normal cords at the edge of P2, coming from the posterior papillary muscle. And this is a pledgeted, there's a pledget on the Gore-Tex suture that I'm placing through the papillary muscle. There's not much of a fibrous cap here, so I'm going through the muscle itself. The pledget should lie behind the papillary muscle, and the sutures themselves should come out in the inflow here. It's important that the suture, that the neocords don't cross any native cords, else they may abrade through them and lead to rupture and new disease. And here you can see it's really quite strong. Now moving on to the anterior papillary muscle. Try and avoid touching healthy cords with my forceps. These are Rosano forceps, but here I'm grasping the fibrous cap of the papillary muscle. These sutures are not tied at all, they're just left as a U-stitch through the papillary muscle. And I think this allows the two limbs to equalize their tension nicely. Okay, that's 2 cords placed. Now then, the cords are sutured through the edge of the leaflet. One limb of this goes through once, and one limb goes through once and round again. So the first one has gone through once. And now the second limb will go through twice. And this allows the leaflet to be moved up and down on the cords, but also gives it some degree of friction, so the leaflet doesn't move when you're doing the water test, which is what I use to size the length of the cords. And the same at the other side. This one going through twice, and the other one going through once. So that's it. Now we put the annuloplasty ring in and have to pull the cords through from underneath the ring so that they lie free. And the ring is tied down. The ring's tied down, and now do the water test and adjust the cords to the correct length. So there you can see the closure line is quite anterior. We want to have a closure line somewhere down here. The post leaflet is bowing, even though the valve is competent. But the leaflet needs to be shortened. So now pulling on the post leaflet with forceps can push the leaflet into a more normal closure line. So here now you can see a much more posterior closure line. I thought that part was perhaps a little bit too far into the ventricles. I was pulling it back a little bit. And then the Gore-Tex is tied. When tying Gore-Tex, I always say that the knot should look ugly, so I tie 3 throws. With all 3 throws all going the same way, you can move the leaflet up and down still a little more, change hands again, do 3 more for a total of 12. And this is the post-op echo. So the long axis view, you can see there's plenty of coaptation here, probably a centimetre, and no regurgitation. And the bicommissural view, you can see that P2 no longer pops up above it, and again a competent valve in that view too. In doing the edge-to-edge technique, it's important to take very good bites for about a centimetre, and this forces coaptation, and you end up with this double orifice valve. It's not a technique I particularly like, but it's certainly used by some surgeons, and they get very good results. Cordal shortening, I'm only showing for completeness. I don't think this is a good technique for pulling down what is already probably a diseased cord. This is technically quite difficult, and I certainly don't recommend it. Cordal transfer, or the flip over technique. Here we have an A2 prolapse. A segment of P2 is resected. These are normal chords which we know are at the right length, repaired as per a quadrangular resection. I don't recommend it, but it's there of historical interest. Taking away normal healthy tissue, I don't think is the best way to repair a valve. A caudal transfer itself. This is an illustration from Nick's Madeire's article. Gilles Dreyfus is certainly very keen on these techniques, taking the secondary cord, which we know will be at the right length, and using that to replace a diseased primary cord. Papillary muscle shortening, actually, because it's in Carpentier's book, it's extremely difficult. You're still leaving diseased cords behind, and I don't recommend it. However, papillary muscle shortening itself does have a place, particularly for the posterior papillary muscle, leading to posterior commissural prolapse. The posterior papillary muscle has three fairly distinct heads. Cords arising from the anterior head go to the anterior leaflet, the posterior head go to the posterior leaflet, and from the intermediate head, and placing a suture through the intermediate head, bringing it down through the posterior head, you can pull the whole commissural complex down. It's not too difficult a technique, and it's really quite a successful technique for posterior commissural prolapse. So this is anterior leaflet prolapse, an anterior directed jet. Now what I want you to notice here is just how small the normal posterior leaflet is. And I think that this small posterior leaflet is one of the reasons why anterior leaflet repair is less successful than posterior leaflet repair. Because you probably, if in doubt, need to undersize a ring here rather than in posterior leaflet repair, if in doubt, probably take a larger size. So my technique is almost identical. You can see the normal short posterior leaflet, less than 1 centimetre in height. The anterior leaflet has got some excess tissue. Here we have A2 with some excess tissue. And here you can see a ruptured cord on A2. So taking the papillary muscle, placing the Gore-Tex cord through it again. Again, not much of a fibrous cap, so I'm going through the papillary muscle itself. But the pledging helps stop the leaflet cutting through, cut the suture cutting through. Remember, the Gore-Tex is not tied on the papillary muscle. I know some surgeons use a technique that does rely on it tied, but I didn't. That was the posterior papillary muscle. Now going to the anterior papillary muscle. Sometimes you put a small swab down here on the infrasurface of the heart that helps push up the posterior papillary muscle, but here I was able to find it fairly easily. So for a fairly short probe here of A2, I'm just using 2 pairs of cords. Oh no, a third. And they're placed through the edge of the leaflet. For most cases, perhaps 2 or 3 millimeters away from the edge of the leaflet, the needle goes through. Where there really is a lot of excess tissue, you can use this to take some of that tissue away, and then I'll perhaps go 5 millimeters. It's important not to place the sutures too widely apart, or else you reduce the coaptation area and can cause a like a corrugation in the leaflet, which may lead to a leak. The second pair of cords going through, one limb goes through once, one limb goes through twice. Okay, and then we put the suture, the ring into place. Mold is removed, and then using a hook, pull the cords through the ring. Again, look at how small the normal posterior leaflet is. So the ring's now tied down. When that's in place, we do the water test to adjust the length of the cords. So it's probably right about here. Here, a little bit of needs to go a little bit further into the ventricle. With just 3 throws, and then do the walks again. Move the foot at this stage. And if I'm happy with the water test, the rest of the knots, I leave my knots on. Some surgeons like to underneath the ventricular problems with doing. And then we have a post-op echo. You can see no prolapse of the anterior leaflet. You don't see anything like as much coaptation in the echo as you do with a posterior leaflet prolapse, simply because of the small posterior leaflet dehiscence. Really, it is almost it's a monocusped valve now, and there's no significant regurgitation. Okay, thank you. That's my technique of mitral valve repair, shown on the anterior and posterior leaflet. And thank you for having me as a guest today. I'll unshare my screen.
That was an excellent talk, Mr. Livesey. I have personally I've been trained by you doing these operations, and I've seen you operating, and you just made it look so easy when you do these cases. It's just amazing. And then when we started doing it, it all becomes so difficult.
I know.
It's an amazing. But thank you very much. I think Hunaid needs to leave, so I will start with Professor Hunaid Bora, and then we'll go through our panelists to see to take their input, and then also if anyone has got any questions, please put it into the chat box here. Hunaid.
Right, Mr. Lilly, that was a great talk. As always, I really enjoyed your description of your techniques. Having worked with you for 12 months, that was the best time of my life. And after having spent 12 months, you kindly supported me to go to Al Khoury to see further about reconstruction.
Sorry, Hunad bhai, sorry. Can everyone please mute their mic? Dr. Fazle Rabbi, I think your mic is on. If you
And that despite having seen a few mitral surgeons, I find that Mr. Livesey's technique is simple and reproducible. It doesn't complicate things any more than it needs to, and you get very reliable results. And he kind of utilizes the commonly used 3 or 4 techniques. So no, I mean, I would fully recommend anyone to use these techniques. They work well and with very little degree of recurrence and reoperation at long-term follow-up. Having written some of his results up as well, I know that very well. I've written down a few things. You might not have time to discuss all of these, but having done a few more of them now independently at Bristol, I've come across certain situations where I really like Mr. Livesey's opinion. I would have probably liked to kind of call him and talk to him about these few issues that sometimes arise, crop up every now and then. First and foremost, the issue of fibroelastic deficiency. It's an interesting valve. Sometimes you don't discover the valve until you go inside and look at it and you find, hang on, this is not the typical myxomatous degenerative valve or the Barlow's valve, and this is fibroelastic deficiency. And despite my kind of level best application of the knowledge and the experience I have, I find it difficult to repair this valve, and the chances of success I have found are significantly lesser as compared to a myxomatous degeneration or even a Barlow's valve. The tissue is very small in amount. There is very little room for plication and resection. And even though you try and repair this, the tissue itself is deficient. It's not excessive, it's deficient, and you can end up causing more trouble and then end up replacing the valve. So that is one point. I don't. You want me to mention the other ones first, or would you like to try and answer this first, and then I can move
Yeah,
on
I do use the same principles for fibrotic deficiency using neocords. I've been using CV5 for this sort of thin tissue over the last few years, which actually has almost the same strength as CV4, but it is a thinner suture. But I do understand what you're saying, but I do use the same technique, same principle.
And you think the short and the long-term results of fibroelastic deficient valves are the same as myxomatous degeneration? Is the valve itself is a problem as well, isn't it?
I do. I mean, of course, we're talking about a much older population, so probably they don't have the longevity any. I can't bring to mind any ever personal anecdote. I haven't really noticed any difference in the outcome.
I do know that P2 resection was in neocords in the P all over UK, and I know I know the incidence of repairs. So, but what our database in UK doesn't show us whether the P2 repair was a resection or neocords. And again, I'd like to know your feelings. I mean, there's something clinical evident, but there's something called gut instinct and gut feeling, and experience tells you that whether resection is better than neocords in the P2 or vice versa. Is there any higher incidence of isolated resection versus isolated neocords? And the gradient after the valve, do you think it is higher in P2 resection compared to neocord in isolated P2 valves?
P2 resection and gold standards is how we all came in doing a lot of them, and hopefully working in centres alongside experienced surgeons so that they can be well taught in those techniques. But I don't see in principle any reason why mini-invasive surgery wouldn't be as good as stenotomy. I mean, something like Patrick Perrier does about 5 stenotomies a year. In over 200 plus mitral valve repairs a year. And I think, having mastered the techniques, then yes, and sticking to the 3 key principles of a good surface of coaptation, restoring proper leaflet motion, and remodeling the annulus, you should get good long-term results.
Fabulous. And I know, Mr. Livesey, you've been kind of an Edwards proponent in terms of the ring selection you've done over the years, and I do understand you probably still use a Physio 2 ring, which kind of we wrote up a few years ago, your experience of the first 100 rings. Do you have any idea, because you work closely with industry and new development innovation, are there any upcoming rings which will reduce the limitations of the current rings that we have, or do you think we've reached a pinnacle here and there's nothing more to add to the design of the rings used for degenerative mitral repair?
I'm not sure how important the design of the ring is, to be honest with you. One change that I perhaps have made since we worked together is I use more Cosgrove bands than I used to do, and I use a band now. Particularly if it's going to be a relatively small ring, then I use a band, because I think probably you do get a lower gradient with a band than with some of the smaller rings. So that is one change I've made. I think the flexible base for the leaflet is quite a good innovation, but by far the most important thing is more important than anything else in mitral valve surgery, whatever technique or ring you use. It's having no.
There'll be one last one now, promise.
Yeah.
The mitral clip.
Yeah.
So mitral clip is here, and we can see, the cardiologists are invading more and more with more and more low risk patients.
Yeah.
And moving into the degenerative territory. And we know there is a randomized control trial run by Joanna Chickway comparing mitral clip versus any mitral repair, minimally invasive or not, in patients less than 65 years of age and with low to moderate risk. What are your feelings about mitral clip? Because it applies the concepts of Alfieri stitch and without any annuloplasty ring. Do you think that will stand the test of time, or this is a reality which we all have to face, and eventually?
I think it's important to do the trial. I would have some concerns about 3 mitral clips in place in a valve for a long period of time. It's not an Alfieri. Alfieri is a relatively neat technique. whereas 3 mitral clips holding the post leaf together is quite a chunk of artificial material there. So I would have concerns about the longevity of it, but I would have thought in the short term they would get excellent results with the sort of valves we're operating on, because they're the easiest ones for them to grasp with a clip.
That's great, fabulous. That's it from my side, and thank you for your talk again.
No, and lovely to see you again. Lovely to see you again.
Thank you very much, Sinead.
Yeah.
Thank you very much for joining us today. I'll go to our next panelist, Mr. Neil Cartwright. Neil, do you have any question or comments on this presentation? Yeah.
Hi. Thanks, Saeed. It's fantastic. I never had the good fortune of working with Mr. Livesey, but my mitral valve repair techniques look very similar, so I'm kind of reassured. I guess two questions that I think would be great. I'll start with what are your thoughts on the neocords being done minimal access, sort of the harpoon style cords, or I know you've been involved with those. What are your thoughts on those?
So harpoon, for those that don't know, was essentially transapical cords done through a very small left anterior thoracotomy on the beating heart, not using bypass. I mean, it was a fantastic thing to do. You put the cords through the prolapse, pull it down, the regurgitation disappears, the blood pressure goes up, the ventricle gets instantly smaller as the volume distribution changes, and we had good results. However, it really hasn't taken off. Certainly not in the States. They ran a registry study in the States, and recruitment was very, very slow. And Edwards have taken it off the market as perhaps non-viable at this stage. But I did like it, and I thought it really had a place. And certainly the early results were good. But you had to have the right patient where pulling down the leaflet will give you coaptation. Of course, there's no annuloplasty, but what we did find in that study is that dimensions changed straight away. At discharge, the ventricle has reduced. Yeah.
Okay. So my next question, I guess, is the ischemic mitral valve. Should you ever repair this, or should you replace it? And if you're going to repair it, how do you choose which ones to repair?
I think they should probably all be repaired, to be honest. I think if you look at the CTS net study, it's done a bit of a disservice, I think, to us all. But in their valves where they repaired the valve and it was competent, there was a big reduction in the ventricular parameters, showing that if you get the repair right, it's a very good technique to use. My preferred ring, I put an IMR ring in, which, for those who don't know, it's a fairly rigid ring, and the P2, P3 area is bent towards the ventricle, which one of my ex-registrars just presented at the ATS.
Yeah, very interesting. Did you ever extend leaf with patches?
The Canadian technique? No, I've not done that. I have approximated some papillary muscles, which does seem to help. I think Schaefer's ring and string approach is also very clever, where you look down through the aortic valve and you can pull the stitch up. But for most patients, I found an IMR ring is very helpful. It works very well. I think the ones where it really doesn't work, and this perhaps came out of the Leiden study, they weren't using an IMR ring, but they were just that was Dion's undersizing by 2. they found that if the ventricle was really large with an EDD greater than 65 millimeters, they didn't get good long-term results there. And they would put a VAD in those patients now.
Great, thank you. Yeah, I'd say the one time I wouldn't attempt it personally, if the tenting height of the valve, so that's the height difference between the annulus where it should be, and where the coaptation point is. If it's greater than a centimetre,
valve.
yeah, yeah, great.
So do you have any comments, questions? So your mic is still mute.
Right. Thank you, Asif. I think we all have enjoyed the talk, which has been very elaborate so far. Mitral valve repair has been done. And when we, at this end, we have been trying to, repair mitral valve for a long time. And triangular resections and quadrangular resections done few. But my question is two questions I have. One is, say, for ischemic mitral regurgitations, situations like where where the annulus is dilated. In this part of the world where some, hospital, so the technique we learned without putting a mitral ring, that 4 centimeter difference felt.
You're frozen on my screen, but yes,
Yeah.
I learned a similar technique from Scott Rankin when I was working at Duke, and he would run an ethibond suture from the posterior commissure down to the middle of P2 and tighten that, and got really quite good results with that technique for ischemic mitral regurgitation. And he published that quite widely.
Yeah, got a very good result, especially
Yeah.
where their ring was not available, and this was sort of a bailout technique. I think we'll get back to Professor Jahangir Kurisa once he's back. I'll go back to our next panelist, Professor Farooq Ahmed. So, do you have any questions or comments?
Thank you, Asif, for arranging this beautiful program. And I have done not much repair, but to me, as the Professor Dr. Steve Lepsy was saying, or he was doing, it looks so easy and competent, and everything is in a very short time. When I try to do this thing, it takes time, and well, there is always some leak, and then again I try to repair it. And what haunts me is that the arrest time is going longer and longer. So in that case, I replace the valve. But I found especially the regardless short torn coding, the repair is good and durable. And in the follow-up period of the patients, they have got very much encouraging result. And to me, looks like what I feel, it is important to realize or understand the exact pathology for that patient, for that mitral regurg, which part is to be corrected and how to be corrected. If that understanding is right or okay, then the correction is okay. But most important thing is to understand the pathophysiology of regurgitation, probably. And that's my understanding. I do cases. So most of the time we have to replace rather than repair. But if I get chance, I try to repair them.
Yeah.
Thank you.
Thank you very much. I mean, is in a different
Yeah.
ball game, and also the presentation of isolated P2, P3 we don't get very often, because without symptoms, patients don't tend to go, and even with symptoms, they go very late. Yeah. So when they come, it's actually quite in the stage. There actually has been a question in the chat about that, Mr. Livesey, if you have any experience or any advice about in rheumatic mitral
repairing is not something that I would do in the UK. You know, valve in my setting is the right thing to do. I have repaired quite a few patients who had rheumatic an episode of acute rheumatism, and they've done very well. There the cords are elongated because of the infection, and they've done well. But the techniques of peeling the tissue off rheumatic valve would you know, I don't see enough patients who would be suitable for that. Most of the ones that are in the UK population are heavily calcified, and I think, you know, so not repairable by somebody of my experience. There was a question about the Gore-Tex cords on the chat box. Yes, the reason for putting 1 through 1 and 1 through twice the cord you're adjusting for height, and it works well.
Yeah, there was another question about the cord. You put the platelet on one side of the papillary muscle rather than both sides. So did you notice any problem or any chance of injury to the papillary muscle because not having the platelet on the other side?
No, I haven't. If you think back to that slide where I showed you the pressure changes in the cords, if you've got coaptation, there's actually very little pressure on the primary cords, which are simply there to cause that motion and lead with coaptation. And once you've got coaptation, the pressure's taken off the cords completely.
Yeah, that's a very good point. So it doesn't matter whether you have platelet on both sides or not. It should not actually erode the papillary muscle if it is competent enough. But then again, if there is a leak going on, then that will be an ongoing issue anyway. Yeah,
maybe I can just add to that, Neil Cartwright here again. I think you'd only want to pledge it on both sides if you're going to tie it onto the papillary head. And I never the papillary head is ischemic and it will come out. And you also evens out the tension, and if you adjust it, otherwise you could have one cord tighter than the other, which is prone to failure. So I think that second pledge it would be for people who tie it, and I think there's a
Thank you very much, Neil. Shakil, Dr. Shakil Farid, Shakil, are you still around?
Thank you very much, Mr. Livesey, for an amazing presentation. Policy chair when I got my number, and your trainees speak really highly of you. You're probably one of the very few surgeons in the country who actually train people how to do a mitral valve repair. And I think it's really important to recognize that. So hats off to you, and a huge thanks to you, what you have done for the trainees all over the years. Now, the ground reality in Bangladesh is slightly different. There are either rheumatic or ischemic. Very few of the patients are degenerative. So just a general comment that if you are setting up a mitral program in your institute, how would you go about that? How would you do the process? I think it's really important for the Bangladeshi surgeons to know. Would you kindly tell us a little bit about how to go about with that? And of course, how do you, if you want to develop a minimal invasive program going forward, you would do
I
that?
think
Thank
the
you.
most important thing in mitral valve surgery is to be able to see what you're doing. Whether you use minimally invasive stenotomy, it's to work so you can show you how to see the mitral valve properly. Because if you can't do that, you can't really do anything. I think in a country where there are few cases of degenerative mitral valve disease, it will be helpful if fewer people were operating on them, so that you could build up some expertise. It's very easy to look at videos of people repairing valves. When I qualified as a consultant, I'd only seen 2 mitral valve repairs, and I largely learned mitral valve repair from going to Alain Carpentier's Club Mitral, where he would operate in a lecture theatre on 2 cases a day, and that's how I learned, just from watching him. So I think the equivalent of that today is probably the internet, and of course it is easier to visit places to see what they do. I think as far as doing minimally invasive surgery is concerned, clearly the best way of that is working with somebody who is already doing it. But if that's not possible, what Patrick Perrier, who's probably the leading exponent of minimally invasive, and make it smaller and smaller and smaller over time as you get more experienced.
Thank you, Mr. Lisi, for your insight. So I'm a very occasional mitral surgeon, only do mitral replacement when necessary. How do you deal with MAC? I know it's a whole new topic, but if you're doing a mitral replacement in a patient with MAC, what are the strategies you take?
I published a paper many years ago, I think with Hunaid, where for most patients, especially the elderly, I don't decalcify. I leave the calcium there and place the stitches around it, and haven't really had any problems in doing that. I have had some problem. I mean, I had a patient who really calcification was so extensive that I couldn't get stitches around it or through it. And in decalcifying it, it was going right down into the ventricular muscle. It was a complete nightmare. But for the majority of patients who are usually elderly and frail, I don't decalcify.
Well, thank you. Yeah.
Some years ago, Tyrone Day presented his results of decalcification. His mortality rate for that was 10%.
Yeah.
So if Tyrone Day had 10% mortality rate.
Absolutely.
There are times when you do need to remove calcium. Technique is very useful at getting out the annulus, but for patients who are elderly ladies who were replacing the valve, I leave the calcium.
I mean, in desperate situations in our institute, we have put some TAVI valves in as well.
Yeah.
Where the MAC was at least 2/3 of the annulus. Obviously, we did it in association with a cardiologist.
Yeah.
So thanks once again for your time on a weekend. You took this trouble to give us this fantastic talk, and thanks to all the panelists as well. And great job, Mr. Saeed Sadiq, on getting such great panelists. Besides the panelists, we also have some senior professors like Professor Fazle Rabbi from NICVT Pakistan. We have Sanjay Asopa, a consultant from Plymouth. So thanks to all of you for joining.
Thank you very much, Shahid Bhai. And Mr. Livesey, you remember also in these sort of MAC cases, they used to put an extra layer from the left atrium, sort of. So when you put the valve in,
it hasn't seated down quite well. Pull up some atrial tissue and situ that.
And that worked really nicely as well. Okay, so I would like to go to our next panelist, Dr. Prashanta Kumar-Chanda. Dr. Prashanta Chanda, are you on? Oh, yeah.
Hello. Many congratulations, Dr. Steve. It was actually amazing talk, full solution for the actually different scenario. At least 70 to 80% of our concomitant ischemic mitral repair or rheumatic mixed lesion or stenotic lesion. So, but we have a limited experience of mitral repair in this part, but definitely at least 10% of the practicing surgeon facing those things. So from this lecture, from this today's future direction as well, especially for the MAC and others, once in a blue night or day, we can face this. So from this discussion, as well.
Thank you very much, Dr. Prashanta. Next, I will go to my friend, Dr. Ashraf Siam. Siam, do you have anything you want to add or any questions?
Thank you, Asif. It was a great presentation. Everybody appreciating it. And I saw the whole presentations. And our senior professor also said that there are a lot of rheumatic valve is facing here. For that reason, we face very popular in Bangladesh. We are struggling on it to repair in mitral valve in Bangladesh. I have a question to Steve. Do you have any experience the mitral valve repair through minimal invasive? If you have that, then you can share it. And again, thanks you.
I have, but I didn't and stayed as a stenotomy surgeon. But you know, I have utmost respect for those who do it that way, and I think you know, as long as you work in a team where everybody knows what they're doing, knows what your techniques are, you know, the results you should expect are exactly the same as with through a stenotomy.
Okay, thank you all, and it was a great discussions, and thanks for the plenary help care for this nice presentation and organizing on it. Thank you, everyone.
Thank you very much, Siam. I'll go to our next panelist, Professor Nazmul Hussain Shuman. Professor Shuman, do you want to have add your comments or any advice?
Thank you very much. I'd like to offer thanks, my special thanks to Professor Dr. Livesey. It was an excellent demonstration, and we all have been benefited. The problem in Bangladesh as it is valvular disease, and many of them are quite young, but gradually these days, the number of ischemic cases are also increasing. Regarding rheumatic valvular repair, I know that some of the Indian surgeons, particularly Professor Sampath Kumar and also some surgeons in Vietnam, they have long series with mixed results. But one issue I would like to raise here to both Dr. Livesey and especially to Shakil and Saeed, Asif, I mean, that in Bangladesh, because well, of course, there are several reasons for this. Most of the valves are rheumatic, patients are young, and so most of the surgeons done to popularize valve repair techniques in Bangladesh because it suits the Bangladeshi patients nowadays, because many of the patients are now presenting at a much older age, and it is also economically viable as compared to the tissue valve here in Bangladesh. So do you propose anything you could do on behalf of this organization to popularize these techniques in Bangladesh?
Can I answer? Yeah, thank you, Shuman Bhai. You have actually made a very important point. I think one of the the things about developing a mitral repair program is to have a proper process. So you guys need to have an MDT in Bangladesh, where there's a dedicated cardiologist who looks at the images in detail. Because if you think of it, as you have said, 60 to 70% of the cases are rheumatic or ischemic. You can argue that you can just get away by doing mitral replacement in those patients. But for the remaining 20 to 30%, what you need to do is have dedicated few surgeons who have high volume of cases. Now, it's extremely difficult because I worked with Jebrin, who does a lot of mitral repair. He used to get some of these cases, and they used to take quite a long time, even in experienced hands. Now, going back to your second question, how can we help from Planetary Health Academia? So you know Rafi, who is here, he was an observer here in Papworth for 2 months. He has seen lots of complex aortic cases, lot of some repair cases, and a lot of transplant cases. So I think perhaps what we can do is from Planetary Health Academia, the next travel fellow we bring will bring a dedicated mitral surgeon and make his rotation in such a way that he gets to see lots of open mitral repair, followed by minimal invasive mitral repair. That can be done, and we can do it through the association. I mean, the president is here, Professor Farouk, and the Secretary General, Ashraf Ulsiam, is here. And, you know, if we get a nominated person, or nominated 1 or 2 persons from Bangladesh surgeons who are slightly at senior level, who can pick up things when they observe the surgeries, we can always do that. I mean, Neil does a lot of mitral in our center. Mr. Frank Wells is there, who is a very high volume mitral repair surgeon. Mr. Narain Mujani is there. And then you know, there are Hunet Vora does a lot of mini mitrals as well, so we can organize that. I'm sure Neil will be very happy to, you know, help Bangladeshi surgeons develop that establishes minimal mitral practice. We can always take a team sponsored by us completely to Bangladesh to help with that. So, you know, we are open to time to go to Bangladesh as well to help the local surgeons. We can organize that.
That was an excellent suggestion, Shakil, and I'd like to just add that the association can also organize some wet labs here, wet lab sessions when these surgeons will be visiting, because 1 or 2 surgeons dedicated, that's an excellent idea. That will transfer the technology to them. But with that, if we can have a wet lab session here with visiting surgeons, maybe for 3 days, I think that will encourage many others to join as well. So in the combination of these two can popularize this in Bangladesh.
Thank you. I just wanted to add something there, that we are organizing the London Core Review course in Bangladesh in February next year. And we plan to hold a wet lab session in that. Professor Alkori has confirmed that he's going to go to Bangladesh. So that will be a generic wet lab, which will include some valve sparing root replacement, some mitral repair. But if you guys are interested and you give me a specific proposal, if Mr. Livesey, you know, is agreeable, we can, if Mr. Livesey has time, and organize a wet lab dedicated to only mitral repair surgery, and then probably, you know, some live cases can be done. I don't know, what are your thoughts, Mr. Livesey, about going to Bangladesh for a few days if we sponsor you?
I was actually about to ask Mr. Livesey about that, and just to say that I've actually joined one of Mr. Livesey's course on wet lab on mitral valve repair on my early stages of training in London, and that was it's organized. That's what I'm trying to say. It's not very difficult. to organize. I have done one wet lab in Bangladesh recently, and Shakil Bhai is doing one when he's going next. And we have got the heart, the cow's heart, which is actually pretty good for the surgeries, and we can get the materials the way we process, and we can definitely organize a very good wet lab in Bangladesh. And as Shakil was saying, that if you agree, then I'll definitely would recommend Mr. Livesey to be there. I mean, he's an excellent trainer.
Absolutely.
And but then I mean, also we can get more people depending on the requirement and the type of training you would like to have.
Yeah, I think any hospital
yeah.
can accommodate that, and they can organize. Even in our hospital, United Hospital, this can be done. Or any hospital they are interested. I mean, so far, mitral valve repair and aortic valve
Yeah.
surgeries and aortic arch
Thank you very much, sir.
surgeries can be done. I mean, that's a very good of you, and also very good of the organizers for the upcoming surgeons.
And,
Thank you, Jahangir Kobi sir. I mean,
and we can assure
those
that
who don't know that, yeah.
Yeah, and we can assure that in February the weather in Bangladesh is fine. So you are
Absolutely.
most welcome.
I hope the political situation is fine. That's what I'm more worried about, because it's a post-election time. February probably is one of the best times to go to Bangladesh. And on that note of Professor Jahangir Kabir, sir, is that our planetary from United Hospital and Incepta as well, because you know we are overseas. We are dependent on funding, and United Hospital, where Dr. Jahangir Kabir works, has been extremely helpful in providing the funding. And this is everything is used for the Bangladeshi doctors so that they can get educated. The Junes people like Professor Jahangir Kabir, Shumon Nazmul Hussain, because they do a lot of stuff much better than we do. At the same time, we do things which they're not used to. So I think this, so when I'm going to Bangladesh next week, I'm actually taking some expired devices like AMDS device, frozen elephant trunk, some valve conduits and expired mitral rings and other stuff that can be used for the wet labs. And we will organize that from our platform. Thank you.
Very much, Shakil. It's a very great movement, and I think it will benefit everybody. I've got two more panelists to go through, then we'll go through some question. I've got Dr. Harun Rashid, Dr. Harun Bhai. He's an associate professor and consultant in the National Heart Foundation. Do you want to give your comments or any questions?
Excellent presentation, Professor Livesey. We have all enjoyed your presentation, and I must congratulate Dr. Shakil and Dr. Asif as well for organizing such a nice program for everyone. We all enjoyed, and we learned it here for almost from 2014 on. But pretty large experience of for Bangladesh as well. Most of our cases are remitted, and also nowadays. I enjoyed your technique of neocord placements, because adjusting the height of the neocords once it is placed times, and excellent presentation again. And another thing that Dr. Shumon Bhai has said that about the starting the mitral repair program. Mitral repair program needs a lot of help from the echocardiographers as well as the anesthesiologists, and it is a multidisciplinary approach. And you need cooperation from all those people as well for giving you the preoperative data and paraoperative data, and also postoperative evaluation of how the repair is. And for that, everyone has to have an act. But mitral repair patients, I must say that repair patients are a total different group of patients than replacement. Replacement patients are repair patients, sir. A repair valve actually repairs a life. And to me, every mitral valve, if it is particularly regurgitating or even mild to moderate MS, can be repaired, or at least should be attempted to be repaired. I congratulate again Dr. Shakil and Dr. Asif for organizing these things, and repaired patients in Bangladesh as well. Thank you.
Thank you very much, Harvey. You just highlight a very important point. During the surgery, you need a good anesthetist who can do a TOE and tell you actually if there is where the problem exactly is before the surgery, after the surgery, how the surgery went by as well. Especially the MDT will help you to get those patients even earlier rather than late presentations. If you got a big, and to get them to surgery. And the last we've got Dr. Arman Wadud. Arman, hi, are you still around?
Thank you, Asif, for organizing such a wonderful program. I think it's very useful by the program. And thank you, Dr. Lipsy, for your nice presentation. The issue is, actually, everybody also already mentioned that we need a lot of wet labs and workshop before we actually get oriented with the. As everybody knows, the mitral stenosis, or especially rheumatic cases, is not the cases for the beginners, but maybe some ischemic MRs you can easily repair, or so you can practice some ischemic repair, or some chordae ruptures in ischemic heart disease. You can start with that, but we need actually, apart from the with the echo TOE, actually oriented with the TOE. So I think on mitral repair, we need a lot of workshop on echo as well, so that people get oriented with the good repair, good mitral valve anatomy, and they can address easily what should be done in mitral valves. Thank you, everybody, for your inviting me.
Thank you very much, Dr. Rahman. That's really helpful.
Asif, there's a question on the chat box for Mr. Lipsy from Sadia. If you could briefly talk about the role of transcatheter mitral valve replacement.
I was just about to go through the chat box. No, thank you very much, Dr. Ray. Yeah. So Mr. Lipsy, do you have any advice?
Well, it's an emerging technology that we probably can't afford in the UK. I watch it with interest to see how it develops. It's our health service is many years away from being able to utilize it as a first line tool. So I expect Bangladesh will be the same. But yes, it's feasible. There are several devices out there. Their problems are, first of all, grasping the anus and staying there, and then there's the question of what to do with the anterior leaflet, because if you have a cage around the valve, it pushes the anterior leaflet into the outflow tract, which can block the outflow tract. So, but I don't see it taking off in the healthcare environment that we're in the UK for some time. I think the States, yes, Germany, perhaps yes, but
USA, I don't think it has
not
picked
for
up
us.
because I was listening to a talk by Raj Makkar from Cedar Sinai. As you know, he's one of the biggest TAVI operators in the world. And even they are not doing quite a lot of this mitral valve repairs to TAVI route because of the obvious problems you have suggested. I think there has been some attempt to develop that so that it doesn't cause world probably is the more use of Jenna valve.
Yeah, but just one more thing to just, Mr. Livesey, remember when we started the harpoon thing, you did the first case in UK, and luckily I was your registrar that time, and I had the opportunity to assist you with the first two cases. I mean, it's amazing the moment the device goes in. And I was just really, this could have been a really good thing, as Neil mentioned. I don't know, is there any chance of this thing coming back, or is
Well,
still,
Edward's own the technology.
Yeah.
So I think that, you know, it was a business decision to stop it rather than based on clinical effectiveness. Just the take up in the registry study in the States was so very slow. So it may come back. Of course, you know, there's Neocore, the technology is slightly different. I think Harpoon was a very neat device, and like you, I'm sad to see it go.
Yes,
Ray, do you have any
actually,
questions
most of our
or
patients
comments?
are in AF by the time they're referred to us for the surgery. And we need to do the surgical ablation as well. And we have the devices in our institute, but we need to learn the technique of surgical ablation would use. Uh, Having continuously giving anti-arrhythmic drug to the patients after the surgery is actually quite troublesome for the patients, the repair or replacement. And this is something that I think that mitral surgeons need to address and get
Agreed,
involved.
absolutely, yes. Yeah, done a lot of ablation concomitant with mitral surgery. The Cox Misfall is very reliable and reproducible.
There's actually a very good course in Barcelona in November on AF ablation. I mean, we can explore that, whether we can send someone from
We can do that
PHA.
as well. I mean, no, I mean, he's a very pro ablation, and he does a lot of AF ablation because of his mitral. I mean, I think Neil can also add some.
Yeah, I'm addicted to AF ablation. I think there's a real benefit to the patients, and not to forget the tricuspid valve as well. I'm very proactive with mitral surgery. Yeah, I think these are really important to think about.
Yeah, tricuspid valve also get affected with AF very, very frequently. And mitral patients with good ablation will probably have a much better quality of life than what we are expected or we are seeing nowadays. I think this is something that we need to address more and more and get more used to. Thank you, Shakil, for arranging such a nice program.
Thanks to Asif. Did all the hard work. Thanks a lot.
That's all right. Mr. Livesey used to do lots of Divega for tricuspid when I was with him. Like everything is done, we'll just do a quick Divega. Tricuspid is done. Oh, amazing! It's
Yeah,
like
in the elderly, I'm sort of actually Divega. In younger patients, I will put a ring in, but in the elderly,
that means the Divega is something which will easily be done in Bangladesh as well, because you don't need any material other than two Prolin sutures.
Actually, Divega is discredited by many surgeons over the years. But anyway, I do a different type of Divega. This is Prakash Punjabi has a technique of double Pagetic stitches instead of a continuous Divega sutures. and he has demonstrated his techniques, and I found it quite effective for functional regurgits.
Very nice.
I think Mr. Punjabi did some operations in Bangladesh, didn't he? Yeah.
Good. So I think we're nearly 2 hours now. It's nearly 12 o'clock in Bangladesh. If anyone has any questions, anything, any comments, anything before we conclude this session? No, that's very good. Just again, Mr. Livesey, it was really great seeing you after 4 or 5 years.
My pleasure.
And yeah, I mean, I am always in debt for you for the training and what you have done for my career so far. And but thank you very much for joining this talk and giving us this excellent talk. And thank you very much for all the panelists coming on their day off, doing all these things free. Shakil, we need to do some program where we can actually have a snack or something like that, because this online is getting too boring.
So Arman has very kindly organized a wet lab at Ibrahim Cardiac Hospital and Research Institute. So he's in the process of inviting a lot of people. There will be snacks and lunch and everything. Lunch for this session as well, Arman.
We have a good thing organized, no problem. Everybody
Thank you, Arman. Nice. And those who are abroad will need vouchers, Arman. For food.
Thank you very much, everyone. Thanks for joining.
Thanks, everyone. Take care.
Take care.
Just one thing before concluding.
Yeah.
Since we are discussing about organizing visits and technology transfer, just last month, Brazilian Cardiovascular Journal has published an editorial about technology transfer. We have been doing technology transfer for many years with our lights for both the visitors and the recipients.
Sure, very honored. See you. Thank you, Mr. Livesey.
Bye. Take care.
Bye. Thanks, everyone.